Okay, this video is about gastroenterology. First, the physiology and basics in gastroenterology. The enzymes, GI enzymes or hormones like cholecystokinin. It causes gallbladder contraction, gastrointestinal motility, pancreatic exocrine secretion. Secretin is pancreatic exocrine secretion. Basically, promotes the secretion of pancreas. GIP increases incretin activity. Motilin causes gastrointestinal motility. Ghrelin is the hunger hormone, and growth hormone also released. Gastric acid secretion, insulin and glucagon, glucose homeostasis. Pancreatic polypeptide causes gastric motility, satiation. Amylin causes glucose homeostasis and gastric motility as well. And GLP increases activity of incretin activity, satiation. GLP2 gastrointestinal motility and growth. Oxyntomodulin, satiation and acid secretion, and PYY satiation. So all these hormones are there. I need to go through them properly. Okay, so amylase is the one that breaks starch down into sugar in saliva and in pancreas. It's found. It's something not new for us. We've studied this over time that amylase does this. And then the following brush border enzymes are involved in the breakdown of carbohydrates as well, like maltase breaks maltose to glucose and glucose. Sucrase breaks down sucrose to fructose and glucose, and lactase breaks down lactose to glucose and galactose. Moving on to the hormones in more details, as you can see, gastrin is produced in the G cell of the stomach, antrum of the stomach, and stimulus is stomach distension, extrinsic nerves. That's the stimulus, and inhibited by low enteral pH, somatostatin. And actions would be the HCl. It increases HCl, increases acidity, pepsinogen, and IF secretion, increased gastric motility, increased gastric mucosa breakdown, trophic effect. CCK, cholecystokinin. The cells, it's found in the eye cells in the upper small intestine. Partially digested proteins and stimulus is partially digested proteins and triglyceride. And action is secretion, increased secretion of enzyme-rich fluid from pancreas, contraction of gallbladder, and relaxation of the sphincter ovi, and decreased empty gastric emptying, trophic effect on pancreatic acinar cells, induces satiety. All these. Secretin S cells, source is S cell in the upper small intestine, and stimulus is acetic chyme and fatty acids. So it increases secretion of bicarbonate-rich fluid from pancreas and hepatic duct cell, and decreases gastric acid secretion. So this one decreases gastric acid secretion, trophic effect on pancreatic acinar cells. VIP is vasoactive intestinal polypeptide. It's secreted by small intestine and pancreas, and it's neural stimulus. Stimulates secretion by pancreas and intestine. Inhibit acid and pepsinogen secretion. And somatostatin is found in the D cells in the pancreas and stomach. The stimulus is fat, bile salts, and glucose in the intestinal lumen. And it decreases acid and pepsin secretion, decreases gastrin secretion, decreases pancreatic enzyme secretion, and decreases insulin and glucagon secretion. Decreases many things. Inhibits trophic effect of gastrin, stimulates gastric mucus production. So a lot of hormones I need to remember more or less everything regarding them. Next is the gastric acid, GI acid secretion control. So principal mediators of acid secretion is gastrin, vagal stimulation, and histamine. So these are the mediators of acid secretion, and factors increasing the acid secretion is gastrinoma, small bowel resection, systemic mastocytosis, basophilia. Factors decreasing the acid secretion is H2 antagonist, PPI, and hormones like secretin, VIP, GIP, CCK. Okay, moving to the GI infections, very important, a very common topic in the exam. Gastroenteritis, it may occur while at home or while traveling abroad. Traveler's diarrhea may be defined as at least 3 loose to watery stool in 24 hours, at least 3. with or without one or more of the following: abdominal cramps, fever, nausea, vomiting, blood in the stool. The most common cause is E. coli, and Bacillus cereus infection may most commonly results from reheated rice. Okay, something important: reheated rice, Bacillus cereus. And the pattern of illness is acute food poisoning. This describes the sudden onset of nausea, vomiting, and diarrhea after the ingestion of a toxin. So after the ingestion of a toxin, that's when you have nausea, vomiting, and diarrhea. Acute food poisoning is usually caused by Staphylococcus aureus, Bacillus cereus, or Clostridium perfringens. So you need to understand and differentiate which one is what. Okay, E. coli is common among travelers. So when you think about travelers, you think about E. coli. Travelers, E. coli. Water is stool, abdominal cramps, and nausea. There's no blood. So blood is the big one here. Giardiasis, prolonged non-bloody diarrhea. So this is prolonged. This is something we have to remember. It's very for a long time. Okay, it starts gradually. So non-bloody diarrhea. Cholera is profuse watery diarrhea. Is again watery. Severe dehydration resulting in weight loss, not common among travelers. So this E. coli and cholera both are having watery diarrhea, but then common amongst travelers is E. coli. This is not. Okay, the first one that comes with blood is Shigella, bloody diarrhea, vomiting, and abdominal pain. So this blood, bloody diarrhea, vomiting, abdominal pain. So this is traveler. All are specific. Okay, prolonged. Cholera is watery. This is blood, bloody diarrhea, abdominal pain, and vomiting. Staphylococcus aureus, severe vomiting. Short incubation period, severe vomiting. And Campylobacter is like most common in the UK. Flu-like prodrome followed by crampy abdominal pain, fever and diarrhea, which may be bloody. Okay, maybe blood. Complications include GBS. So crampy abdominal pain is the one I think more is specific to it. Bacillus cereus, typically 2 types of illness are seen: vomiting within 6 hours, diarrhea illness occurs after 6 hours, vomiting within 6 hours, diarrhea illness occurring after 6 hours. Amoebiasis is again bloody. So bloody is only A and S. Amoebiasis and Shigella. Whenever you hear bloody diarrhea, okay, gradual onset again. Bloody diarrhea, abdominal pain and tenderness may last for several weeks. So this is gradual again. Which one was gradual onset? Even this one was gradual onset. Which one? Giardiasis is also gradual onset, but no blood. Okay, giardiasis and amoebiasis, difference is amoebiasis may have blood. So Shigella and amoebiasis is bloody diarrhea, and this one has abdominal pain, tenderness, and gradual onset. And Shigella is just basically vomiting, abdomen, blood, diarrhea. This is very important. It keeps on coming in the exam. Okay. If you talk about the incubation period, it's also important. Incubation period 1 to 6 hours. This is the quickest. Staphylococcus aureus, Bacillus cereus, 12 to 48 hours. Salmonella, E. coli, Shigella, and 40 to 70 hours. Shigella, Campylobacter, more than 7 days. Giardiasis, amoebiasis. So in this, amoebiasis will have bloody bacteria. This won't have it. So you have to differentiate. Staphylococcus will have more vomiting, and everything is there. Like this one is cholera, traveler's diarrhea, and yeah. So cholera is caused by Vibrio cholerae, gram-negative bacteria. So profuse rice water diarrhea, dehydration, hypoglycemia. Of course, what you do is give ORS, oral rehydration therapy, antibiotic like doxycycline and ciprofloxacin. All these can help. Okay, E. coli is a facultative anaerobic lactose fermenting gram-negative rod, which is normal gut commensal. E. coli tends to infection lead to a variety of diseases in humans, including diarrheal illness, UTI, neonatal jaundice, meningitis. All this can happen. Okay, E. coli 015787 is a particular strain associated with severe hemorrhagic watery diarrhea. It's severe hemorrhagic watery diarrhea. It has a high mortality rate, can be complicated by hemolytic uremic syndrome. So this one specifically. It's often spread by contaminated ground beef. The presentation is usually diarrhea, renal failure, thrombocytopenia, and diffuse hemorrhage. Next is Salmonella. It's a group contains many members, most of which cause diarrheal illness. They are aerobic gram-negative broths. Salmonella. Aerobic gram-negative broths, which are not commonly present as common cells in the blood. Typhoid and paratyphoid are caused by Salmonella typhi and Salmonella paratyphi. Okay. Respectively, they are often termed enteric fever, producing symptoms such as headache, fever, and arthralgia. Okay, body louse is the vector transmitter of disease. Body lice can spread endemic typhus, French fever, and louse-borne relapsing fever. Although louse-borne typhus is no longer widespread and outbreaks of this disease still occur during time of war, civil unrest, and an unnatural or man-made disaster, and in prison where people live together in unsanitary conditions. Louse-borne typhus still exists in places where climate, chronic poverty, and social customs of war and social upheaval prevent regular changes and laundering of clothes. Features can be louse, I think, salmonella, I think. Initially systemic upset, bradycardia, abdominal pain, distension, constipation. Although salmonella is the cause of diarrhea, constipation is more common in typhoid. Rose spots present in the trunk in 40% of patients and are more common in paratyphoid. Possible complications of salmonella: osteomyelitis, especially in sickle cell disease, where salmonella is one of the most common pathogens. GI bleed per perforation. Then comes meningitis, cholecystitis, chronic carriage. Shigella causes blood diarrhea. Shigella causes blood diarrhea, as you know. Abdominal pain and 48 to 72 hours. Remember that. Severity depends on the sonay from maybe mild explanatory or dysentery from abroad may cause severe disease. Treat with ciprofloxacin. So these are way to remember: Shigella, ciprofloxacin. Okay, now gardiasis, as you know, that it's going to be for a long time. The incubation period is more than 7 days. So it's caused by flagellate protozoa Gardia lumblea. It's spread by the fecal oral route. This is a chronic diarrheal illness that is due to flagellate protozoal parasite Gardia lumblea, which attaches to but does not invade the small bowel. This disease is associated with malabsorption, particularly of carbohydrate and fat. Okay. Presentation is of chronic, persistent, or recurrent diarrhea with very offensive stool. So offensive stool, remember that. Abdominal distension and weight loss. Children may failure to thrive from a lack of fat soluble vitamins. Okay, for gardiasis, often asymptomatic lethargy, bloating, abdominal pain, non-dry diarrhea, chronic prolonged diarrhea, malabsorption, and lactose intolerance can occur. Stool microscopy for trophozoite and cysts are classically negative. Therefore, dural fluid aspirates or string tests are sometimes needed. So treatment is with metronidazole. Gardiasis, you can just say mardiasis, metrodiasis. So to find some ways to remember everything. This is a good way. Okay, Clostridium difficile. Clostridium difficile is a gram-positive rod, often encountered in hospital practice. It produces an exotoxin, which causes intestinal damage leading to pseudomembranous colitis. Okay. C. difficile develops when the normal gut flora is suppressed by broad-spectrum antibiotics. Clindamycin is historically associated with causing Clostridium difficile, but with the etiology has evolved significantly over the past 20 years. Second and third generation cephalosporin, cefuroxime, and ceftriaxone are the leading cause. Okay, so the features of Clostridium difficile infection can be diarrhea, abdominal pain, if severe toxic dilatation, sometimes seen in nosocomial outbreaks. And the management is oral metronidazole for 10 to 14 days. Maybe there are some changes now, not sure. Oral metronidazole for 10 to 14 days. If severe or not responding to metronidazole, then oral vancomycin may be used. For life-threatening infections, a combination of oral vancomycin and IV metro should be used. So starts with metronidazole oral. If severe, then oral vancomycin. If not, then oral vancomycin and IV metro. Okay. Okay, bacterial overgrowth. The gold standard investigation of bacterial overgrowth is small bowel aspiration and culture. The important association can be systemic sclerosis, diverticular blind loop. Other investigations include hydrogen breath test, 14 CXY lows breath test, 14C glycocholate breath test. Okay. Next comes exotoxins. Exotoxins are generally released by gram-positive bacteria, with notable exceptions of Vibrio cholerae. So it's produced by gram-positive bacteria, but exceptions are there like Vibrio cholerae and some strain of E. coli. Okay. Diphtheria toxin commonly causes a diphtheric membrane on tonsils caused by a necrotic mucosal cell. Systemic distribution may produce necrosis of myocardial, neural, and renal tissues. Staph aureus. Exotoxin lead to acute gastroenteritis, toxic shock syndrome, staphylococcus, scarlet skin syndrome. So the exotoxins leads to these things. Cholera toxin causes activation of analyte cyclase leading to increase in CAMP levels, which in turn leads to increased chloride secretion. So all these are important. Helicobacter pylori, another bacteria important. So Helicobacter pylori is basically a gram-negative bacteria associated with a variety of gastrointestinal problems, principally peptic ulcer disease. Mainly that's the problem, peptic ulcer disease. H. pylori eradication, 7-day course for PPI twice daily, plus amoxicillin plus clarithromycin or metronidazole. Penicillin allergy is there, metronidazole, clarithromycin. So clarithromycin is there. You add either amoxicillin or metronidazole. If penicillin allergic and previously had clarithromycin, metro plus levo. So it's AC or MC or ML. Associations can be peptic ulcer disease, 95% of duodenal ulcers, 95% of gastric ulcer, gastric cancer, B cell lymphoma of small tissue, eradication of H. pylori causes 80% regression, atrophic gastritis. The role of H. pylori in gastroesophageal reflux is unclear. There is clearly no role of eradication of H. pylori in GORD. Investigation can be urea breath test. Patients consume a drink containing isotope 13C enriched urea. Urea is broken down by H. pylori urease, and after 30 minutes, patient exhales into glass tube. Mass spectrometry analysis calculates the amount of 13C CO2. Sensitivity 95 to 98, specificity 97 to 98. Used to confirm eradication. Okay. So urea breath test. No antibiotics in past 4 weeks. So for the test to do, you have certain requirement like no antibiotics in the last 4 weeks and no anti-secretory drugs like PPI in the last 2 weeks. There are other tests like rapid urease tests like CLO test, biopsy samples mixed with urea and pH indicator, color change if H. pylori urease activity, sensitivity 92 to 95%, 95 to 90% specificity, serum antibody remains positive after eradication, sensitivity 85%, specificity 80%. Culture of gastric biopsy, specificity 100%, and provide information on antibiotic sensitivity. Gastric biopsy, sensitivity 90 to 99, histological evaluation or no culture. Stool antigen test, sensitivity 90, specificity 95. Okay, Whipple's disease is a rare multisystem disorder caused by. So Whipple's disease is very important as well. It's a rare multisystem disease disorder caused by Trophoema Whipple infection. Is more common in those with HLA-B27 positive and in middle-aged gentlemen. So what happens? Malabsorption. So this one is from soil. It's an infectious disease. Malabsorption causing diarrhea and weight loss, larger arthralgia, seronegative arthropathy, lymphadenopathy, skin shows hypersic pigmentation and photosensitivity, pleurisy, pericarditis. Neurological symptoms are rare, like ophthalmoplegia, dementia, seizures, ataxia, myoclonus. So the investigation jejunal biopsy shows deposition of macrophage containing periodic acid skiff PAS granules. So PAS granules in macrophage in jejunal biopsy. Increased CRP and ESR, hyperalbuminemia. Management can be it varies. Example: IV penicillin, then oral cotrimoxazole for a year. This kind of management. So this will basically show diarrhea and weight loss, malabsorption. This is the main symptom. Tropical sprue. These are all causes of diarrhea actually. Tropical sprue. This disease is most common in the Caribbean and the Far East. It's characterized by a picture of small intestinal malabsorption, and this cause is thought to be infectious in origin. So this is also infectious. Diagnosis: jejunal biopsy reveals mild villus atrophy. So this villus atrophy, and there's increased villus crypts. So this can cause malabsorption. Increased villus crypts, mononuclear cellular infiltrate, enlarged epithelial cells, and large nuclei caused by vitamin B or folate deficiency. So treatment is tetracycline 25 to 50 mg QDS up to 6 months. Ampicillin may be used as an alternative. Folate and vitamin B12 deficiency should also be corrected. Complete recovery possible with appropriate therapy. So that's it for tropical sprue. Next is upper GI disorders. Also very, very important. There's not a lot of things, but yeah, it's important. So upper GI disorders. Pharyngeal pouch. Zenker's diverticulum is a posteromedial diverticulum or herniation through Killian's dehiscence. It's a triangular area in the wall of the pharynx between the thyropharyngeus and cricopharyngeus muscle. It's more common in older people and is 5 times more common in men. So what are the features you see? Dysphagia, regurgitation, aspiration, neck swelling which gargles and palpitation, halitosis. Features of it. And the management would be surgery despite being associated with increased morbidity as majority of patients are elderly. Or endoscopic stapling diverticulotomy can be done. It's becoming increasingly popular. There is no long-term follow-up data. There is small theoretical risk of developing carcinoma within a pouch that is not exercised. Okay, esophageal varices is something which is very common to see in the wards. Acute treatment of ecvaricial hemorrhage ABC. Patient should be ideally be resuscitated prior to endoscopy. So correct clotting. So FFP, vitamin K, that's what you give for the clotting purpose. And vasoactive agents like terlipressin is currently the only licensed vasoactive agent. It's been shown to be of benefit in initial hemostasis and preventing rebleeding. It acts by constriction of the splanchnic vessels, contraindicated in ischemic heart disease. Use octreotide as alternative. So if the patient has IHD, use octreotide. Prophylactic antibiotics have been shown in multiple meta-analysis to decrease mortality in patients with liver cirrhosis. Endoscopic variceal band ligation is superior to endoscopic sclerotherapy. So band ligation is like preferable in these cases. Okay. Next is Sengstaken Blakemore tube if uncontrolled hemorrhage in urgent setting when endoscopy is not ready. And transjugular intrahepatic portosystemic shunt tips if all of these fail. And how you give the prophylaxis. Prophylaxis of variceal hemorrhage is propranolol. It decreases rebleeding and mortality compared to placebo. Endoscopic variceal band ligation is superior to endoscopic sclerotherapy. So better than sclerotherapy is band ligation. It should be performed at 2 weeks intervals until all varices have been eradicated. Proton pump inhibitor is given to prevent the AVL induced ulceration. So PPI also must be given. Upper GI bleed. The guidelines: acute management, IV, excess, and blood. Group and safe, cross-match FBC, clotting, LFT, UNE. Resuscitate crystalloid and colloid while awaiting blood products. Stop anticoagulants and antiplatelets. Consider vitamin K and prothrombin complex. So you stop all these. Consider vitamin K and prothrombin complex. Blood transfusion is very important. Plaqued RBC depending on hemoglobin level. Platelets if platelet less than 50. FFP fibrinogen, if fibrinogen is less than 1 and PT is 1.5 times more than normal. Something very important you have to see in the words, if PT is 1.5 times more than normal. Okay. Prothrombin complex is if on warfarin and actively bleeding. So terlipressin 2 mg QDS can be used, and if ISD is the contraindication, indication use octreotide. Prophylactic base broad-based antibiotic is in variceal bleeds. Endoscopy immediately if unstable or severe bleed, otherwise within 24 hours. Consider inserting a catheter to guide fluid resuscitation. Don't offer PPI before OGD to suspected non-variceal bleeding. Okay, so this is not really maintained everywhere. You always see patients getting PPI from beforehand. Okay, scoring. Scoring normally available online mobile apps or on charts in hospital. You shouldn't need to memorize scoring points. You need to be aware of the components. For example purpose, Glasgow Blatchford rating score to classify severity and guide management. Markers include urea hemoglobin, systolic BP, heart rate, melena, syncope, all these. Hepatic disease, heart failure. Score of 0 can be measured as OP, outpatient. More than 5, high risk, needs urgent endoscopy. So all these things together. Rockall score is also there. Prognostic score for mortality per post endoscopy. Markers include age, comorbidities, shock, source of bleeding. Less than 3, good prognosis. More than 8, poor prognosis. Post acute management, peptic ulcer. Comments: high dose IV PPI 80 mg followed by 8 mg per hour infusion for 72 hours. Peptic ulcer management. And check H. pylori screen and comments eradication therapy as required. This may be a CLO or stool antigen test. Arrange follow-up OGD in 6 to 8 weeks for gastric ulcers. Variceal bleed, terlipressin for 48 hours or until definitive banding is performed. Beta blockers on hemodynamically stable to prevent further variceal bleed. And regular surveillance endoscopy as OP. Arrange first one after 4 days. Okay. Continue low dose aspirin if in patients with history of CVA or MI. Continue low dose aspirin in patients with history of CVA or MI if the GI bleeding has been controlled by endoscopy. So regular imbalance as OP. Okay. Continue low dose aspirin in patient with a history of CVA or MI if the GI has been controlled by endoscopy. Okay, next is dysphagia. Dysphagia is also important. Difficulty swallowing. It's what it means. And table below gives characteristic examining questions feature for condition causing dysphagia. So you need to remember all of them so that you can answer the questions properly. So pain on swallowing at otinophagia is a typical feature of esophageal candidiasis, a well-documented complication of inhaled steroid therapy. Now for esophageal cancer, dysphagia may be associated with weight loss, anorexia, or vomiting during eating. Dysphagia may be associated with weight loss, anorexia, or vomiting during eating. History may be include Barrett's esophagus, CORD, smoking, or excess alcohol. Esophagitis may be history of heartburn or anophagia but no weight loss and symmetrically well. Candidiasis may be a history of HIV or other serious factors such as inhaler use, steroid inhaler use, achalasia, dysphagia of both liquids and solids from the start, heartburn. Regurgitation of food may lead to cough, aspiration, pneumonia. Pharyngeal pulse, more common in older men, represents as a posterior medial herniation between thyroidopharyngeus and cricopharyngeus muscle, usually not seen but if large than a midline lump in neck that gargles on palpation. Typical symptoms are dysphagia, regurgitation, aspiration, and chronic cough. Dysphagia, regurgitation, aspiration, headache may also be seen. We already studied this. Systemic sclerosis, Crest syndrome may be present, calcinosis, venous phenomena, also esophageal dysmotility, sclerodactyly, and telangiectasia. Myasthenia gravis ulcer may include extraocular muscle weakness or ptosis, dysphagia with liquids as well as solids, both. Achalasia, both, and this one also both. Globus hystericus may be history of anxiety. Symptoms are often intermittent. Okay, dyspepsia. Dyspepsia causes increased gastric acidity. So NSAIDs can be given. Sorry, NSAIDs causes increased gastric acidity. NSAIDs bisphosphonates steroids. These three can give cause increased gastric acidity, and LOS pressure reduction, calcium channel blocker, nitrate theophylline can be given. These drugs, okay, which drugs may, okay, we'll come back. LOS pressure reduction drugs may cause reflux by reducing lower esophageal sphincter pressure, reducing, therefore may cause dyspepsia. Calcium channel blocker and nitrates are occasionally used in management of achalasia. So these things can also cause dyspepsia. So in the case of achalasia, these ones can be used to decrease the pressure of lower esophageal sphincter, which will cause more dyspepsia. In 2018 guideline, it's updated its guidelines for the management of GERD and dyspepsia. These consider the age of the patient, younger or older than 55, and the presence of or absence of alarm signs. Alarm signs are chronic gastrointestinal bleeding, progressive unintentional weight loss, dysphagia, persistent vomiting, IDA, epigastric mass, and suspicious barium meal. Urgent referral for endoscopy within 2 weeks if there are alarm signs, irrespective of age, or more than 55 years if recent in onset rather than recurrent and unexplained. New systems which cannot be explained by precipitants such as NSAIDs and persistent continuing beyond 4 to 6 weeks. Management steps in patients who do not meet referral criteria. Review medications and for possible cause of dyspepsia. Lifestyle advice like weight reduction, avoid triggering food, avoid late evening meals, stopping smoking alcohol over the counter antacids, trial of full PPI dose for 4 weeks. Test if positive to treat for H. pylori using carbon 13 urea blood test or stool antigen. Indication for non-urgent upper GI endoscopy, age more than 55, symptoms more than 4, relapsing symptoms. Next is GORD. 24-hour esophageal pH monitoring is the golden standard test for GRD, indicative if the diagnosis is unclear following a negative endoscopy. That is, if it's negative. Management will be generally as an uninvestigated dyspepsia. If diagnosed, offer full dose PPI 4 to 8 weeks. If symptoms recur, offer PPI when needed or regular at lowest possible dose. Offer histamine to receptor antagonist ranitidine if no adequate response to PPI. Don't routinely offer endoscopy to diagnose Barrett's esophagus, but consider if the person has GORD, especially with high risk male, increased duration or frequency of symptom or abnormal OGD previously. Barrett's esophagus is another important thing. It refers to the metaplasia of the lower esophageal mucosa lower. Okay. Mucosa with the usual squamous epithelium being replaced by the columnar epithelium. There is increased risk of esophageal adenocarcinoma, estimated 50 to 100 folds. Adenocarcinoma, not others. Histological features: the columnar epithelium may resemble that with the either cardiac region of the stomach and that of small intestine. Management can be endoscopic surveillance with biopsies. Low-grade dysplasia, high dose PPI for 8 to 12 weeks. High-grade dysplasia, endoscopic mucosal resection for local lesion, radiofrequency ablation surgery can be given. Okay. Achalasia, failure of esophageal peristalsis, and relaxation of the lower esophageal sphincter due to degenerative loss of ganglia from the airback plexus. LOS, contracted esophagus of dilated achalasia, typical presence in middle age and is more common in women. Dysphagia affect both solid and liquid, and dysphagia affecting both solid and liquid from the start. Think achalasia. The clinical features can be dysphagia of both liquid and solid, typically variation in severity of symptoms, heartburn, regurgitation of food may lead to cough, aspiration, pneumonia, etc. Malignant change in small number of patients, 7% increase in risk of squamous cell carcinoma, not adeno, which is in achalasia. This is in Barrett's esophagus, sorry. This is achalasia, squamous cell carcinoma. So Barrett's, adeno, achalasia, squamous. Okay, investigation manometry. Excessive LOS tone which doesn't relax on swallowing. Consider most important diagnostic test. Barium swallow shows grossly expanded esophagus, fluid level. Okay, barium cell also shows expanded esophagus fluid level, wide mediastinum and fluid level. Manometry is on. Treatment can be intrasphincteric injection of Botox, Heller cardiomyotomy, balloon dilatation. Drug therapy has a limited role, but limited by side effects. The golden standard for echolalia is esophageal manometry. Differentiating echolalia from scleroderma using manometry. Okay, how to do it? Echolalia, loss of peristalsis in distal esophagus, failure of LOS to relax. It's very tight during swallowing, and so increasing residual relaxing pressure. And LOS of loss of peristalsis in distal esophagus, but decreasing resting LOS. So both have loss of peristalsis in distal esophagus, but this one scleroderma has resting LOS pressure, which is low, and this one is high. So basically esophageal dysmotility is in scleroderma. Mallory waste here, also very important. Everything is important. I can't say anything is not important or of least importance. So Mallory waste here is bleeding from a non-transmural esophageal tear. This is caused by severe vomiting because of alcoholism or bulimia. Presentation management: presence with hematemesis in context of alcoholism or bulimia, generally self-limiting, and diagnosed clinically. OGD is diagnostic but rarely needed. Treatment is usually supportive as persistent bleeding is uncommon, but if happens, treat as acute upper GI bleed. Boerhaave syndrome is a rupture of the esophageal wall, relatively uncommon but serious and potentially fatal condition. Complete transmural. That is, this one is not transmural. This is transmural. Full thickness laceration or perforation of the esophagus associated with severe vomiting. Perforation is almost always on the left side of the lower esophagus. Okay. Gastric contents enter the mediastinum and pleural cavity. If one were to perform pleural fluid aspirate, one is actually to aspirate gastric content. So this is a tear in the esophagus lower side. So what happens is the gastric content may gets into the pleural cavity and mediastinum. So aspiration may give you gastric content. Male more than female and typically 50 to 70-year-old. Other clinical features that may suggest the diagnosis include odynophagia and surgical emphysema in the neck. Chest X-ray shows pneumomediastinum. Arrows, you see, an esophagram with extravasated water soluble contrast material in left hemithorax. Alright. Causes of this Boerhaave syndrome can be vomiting against a closed blood, it's in eating disorders as bulimia, rarely extremely forceful cough obstruction by food. Diagnosis: chest X-ray shows mediastinal gas, efficient later pneumothorax. Esophagram is used to confirm leak, first with water soluble contrast, then barium if no leak demonstrated. Management: early operation after appropriate resuscitation offers the best chance of survival. Management: early operation after appropriate resuscitation offers the best chance of survival. Okay. Iatrogenic perforation accounts for 85 to 90% of cases of esophageal rupture, typically as a complication of an endoscopic procedure, feeding tube, or ambulatory surgery. So, dangerous. Post-Jogger syndrome, autosomal dominant condition characterized by numerous hamartomatous polyps. Post-Jogger AD, of course, structural, caused by characterized by hamartomatous polyps in the GI tract, associated with pigmented freckles on the lips, face, palms, and soles. Around 50% of people who develop died from a GI tract cancer by the 60. It's unusual to find cases in young adults without the characteristic periosteal hyperpigmentation. Carcinoma. So AD responsible gene encodes serine, threonine, kinase LKB1 or STK11. Features can be hamartomatous polyp in GI tract, mainly small bowel, pigmented lesions on lips, oral mucosa, face, palm, and soles. Classical histological appearance of smooth muscle arborization, intestinal obstruction, interception, GI bleeding. Conservative unless management is conservative unless complications develop. So polyps and pigmented lips. All remember. Polyp, pigmented lip. Okay, short bowel syndrome. Short bowel syndrome in patients who have removal of more than one half of the small intestine, malabsorption may result in patients who already have their small intestine half of it removed. Malabsorption can occur, of course. It may occur in patients with Crohn's disease as well, or those with ischemic bowel who have undergone significant bowel resection. So it's post-op. This is a post-op thing usually. Presentation can be diarrhea, steatorrhea, malabsorption manifestation, weight loss, anemia, osteoporosis, irritable disturbance, hypovolemia. Management is more than 100 centimeters of jejunum. Oral intake is still possible. So if still more than 100 centimeters of jejunum is left, oral intake is still possible. Diarrhea may reduce with lactose exclusion or with a course of metronidazole to eradicate bacterial overgrowth. So yeah, metronidazole can be given. Less than 100 centimeters of jejunum to TPN is recommended. So if it depends on how much jejunum is left out. Okay, esophageal cancer is usually adenocarcinoma is the most common type of esophageal cancer. Adenocarcinoma was more related with what? It was more related with Barrett's esophagus, and squamous cell was achalasia. Okay, adenocarcinoma is the most common type of esophageal and is most likely to develop in patients with a history of gastroesophageal reflux disease or Barrett's. Majority of tumors are in the middle third of the esophagus. Middle. This is where you get 1/3, 2/3, 3/3. H. pylori may be protective against esophageal cancer. Oh, that's good to know. So these are the stages. It's very near to the aorta. The last one. So what are the risk factors of adenocarcinoma? Risk factors are GERD, Barrett's esophagus, as we said before, and squamous cell carcinoma. Risk factors will be smoking, alcohol, achalasia, Plummer-Vinson syndrome, celiac disease, scleroderma. Okay. Squamous cell carcinoma is very sensitive to radiotherapy. Squamous cell radiotherapy. Remember that. Okay. It's like RST. PQRST, right? RST. Radiotherapy and squamous cell carcinoma. Gastric mold lymphoma associated with H. pylori infection in 95% of the cases. Mucosa associated lymphoid tissue that is there. Lymphoma of that. Good prognosis if low grade, then 80% respond to H. pylori eradication. Okay. Peritoneum may be present. Gastric cancer, very important as well. Gastric cancer, overall epidemiology, overall incidence is decreasing, but the incidence of tumors arising from the cardia is increasing. Cardia. Peak age 70 to 80 years, more common in Japan, China, Finland, Colombia than West. More common in males, 2:1. Gastric adenocarcinoma histology, signet ring cells. Okay. Diagnosis endoscopy with biopsy. Of course, we do biopsy to diagnose it. And staging endoscopic ultrasound or CT. Endoscopic ultrasound has recently been shown to be superior to CT. So endoscopic ultrasound to do staging. This is a very common question in the Mrcp. So that's why it's like orange, you can see. H. pylori infection is most common cause of gastric cancer, although protective against esophageal cancer. Blood group A, gastric cancer. Association blood group A. Gastric erythematous polyp, pernicious anemia, smoking. Diet, salty, spicy, nitrates. What? Association, okay. Salty, spicy, and nitrate diets may be natively associated with duodenal cancer. Histology signature ring cell. You have to see that. Okay, so next would be lower GI disorder, very important topic as well, and very high yield topic. So many important things coming up as well. Pathology is also very big, but very important topic, that I must say. That's like very big chunk of MRCP questions will be from the GI tract as well. Okay, the lower GI disorders, malabsorption is characterized by diarrhea, steatorrhea, that is excess fat in the poop, weight loss. Okay, so it's malabsorption in general. So what can be the causes of malabsorption? Very important. Intestinal can be celiac disease, Crohn's disease, tropical sprue, Weber's disease we've studied before. Cardiasis, brush border enzyme deficiency, like decreased lactase. Pancreatic can be chronic pancreatitis, cystic fibrosis, pancreatic cancer. Then others can be bacterial overgrowth syndrome, short bowel syndrome, lymphoma, biliary obstruction, PBC. All these can cause malabsorption. So malabsorption is like a general symptom for all of this. Okay, So one of the disease from malabsorption, we have to go back to the main topic all the time to understand it better, is celiac disease, the first one here. Okay, so celiac disease is caused by sensitivity to protein gluten. We know that celiac disease patients always take gluten-free diet. Repeated exposure leads to villus atrophy. So what happens is gluten leads to villus atrophy, which in turn causes malabsorption. So villus atrophy in the intestines happens and malabsorption occurs. The management of celiac disease involves a gluten-free diet. So gluten-containing diet, what is it? Bread, pasta, pastry, barley like beer, rye, oats, all these. Some notable gluten-free food are rice, potatoes, and corn. Okay, whiskey is made from malted barley. Protein says gluten are however removed during the distillation, making it safe to drink. Conditions associated with celiac disease can be dermatitis herpetiformis, and vesicular pruritic skin eruption. So yeah, and autoimmune disorders like type 1 diabetes mellitus or autoimmune hepatitis strongly associated with the HLA-DR DQ2. 95% of the patient, HLA-B8 80%, HLA-DR3 HLA-DR2. So DQ2 is the one, remember, since it's 98%. So in 2016, NICE revised its guidelines, and the guidelines have changed a bit. This has to offer serological testing to sign and symptom conditions. Sign and symptom can do what? For celiac disease: persistent unexplained GI symptom, failure to thrive in children, prolonged fatigue, tired all the time, unexpected weight loss, severe or persistent mouth ulcer, unexplained iron, vitamin B12 folate deficiency. Conditions: first degree relative of people with celiac disease, type 1 diabetes at diagnosis, autoimmune thyroiditis at diagnosis, IBS. Consider retesting if a person presents with new symptoms of celiac disease despite previous negative serology. Consider screening in metabolic bone disorder, reduce bone mineral density, unexplained neurological symptom, particularly peripheral neuropathy or ataxia, unexplained subfertility, recurrent miscarriage. So these are the reasons why you should consider screening for celiac disease. Persistent liver enzymes, raised liver enzyme, dental enamel defect, Down syndrome, Turner syndrome. Okay, complications can be anemia, folate deficiency is the most common, and iron and B12 deficiency may occur, hypersplenism, osteoporosis, lactose intolerance, enteropathy, T-cell lymphoma of small intestine, subfertility, unfavorable pregnancy outcomes, esophageal cancer, other malignancy. Diagnosis is made by a combination of immunology and intestinal biopsy. That's the most important thing, biopsy. Villus atrophy and immunology. So we've already studied for villus atrophy. This happens in celiac disease. And immunology normally reverse on a gluten-free diet, so it's reversible. The patients are already taking gluten-free diet. They should be asked, if possible, to reintroduce gluten for at least 6 weeks prior to testing. So if you do a intestinal biopsy prior to that, you should stop the diet, gluten-free diet, for at least 6 weeks. Immunology test for total IgA and IgA tissue transglutaminase (TTG) as the first line choice. Use IgA endomysial antibodies if IgTTG is weakly positive, EMA if this is weakly positive. So if IgA is deficient, then consider using the following: IgA EMA or GTP or TTG. IgTTP. Jejunal biopsy, villus atrophy. What you see in the biopsy: villus atrophy, crypt hyperplasia, increase in intraepithelial lymphocytes, and laminar propria infiltration with lymphocytes. So all lymphocytes. So first one is IgA TTG. If it's weakly positive, then you go for IgA EMA. Okay, so jejunal villus atrophy. While celiac disease is the classic cause of jejunal villus atrophy, there are several other causes you need to be aware of. So villus atrophy can also occur in cow milk intolerance, Whipple's disease, gastrointestinal lymphoma, hypogammaglobulinemia, tropical stroke. All these can cause jejunal villus atrophy. Okay, I think we're done for now.